Okay. All right, out there in listener land, welcome back to another episode of Therapy with At the Couch. With me, Dr. G, Dr. Todd Jardina. The always disclaimer, this is not therapy. I'm not your therapist. It's just a funny little tagline to get you in here. Today we have a guest. I'm speaking with Dr. Ingrid Paredes at FemCare OB-GYN, and she's going to be dispelling some myths, explaining some things, talking about some of the stuff that I talk about with my patients, but I don't have the knowledge you have. So can you please introduce yourself to the listeners out there first so they know a little bit more about what's your background and what's your training? How did you end up here? I want them to know you before you start talking.
Okay, sounds good. Thank you so much for having me. So I was born and raised in Cuba. I migrated to the United States when I was 15 years old. I did high school here, college in UF, then went to medical school, then did my residency in OB/GYN in St. Luke Hospital in Pennsylvania. Then I had to work there because my husband, who's also a surgeon, did a fellowship there. So I worked as an attendant there for some years. And then I came back here to Miami, where I'm happy to be back to take care of all my Hispanic patients, all my Cubans and non-Cubans and everybody that I love to take care in all the GYN, OB, mental health, obesity, menopause, adolescence. So I do a little bit of everything.
Okay.
Basically, since I graduated, you graduate as an OB/GYN, but you can do sub trainings. And I did that on robotic surgery, menopause, obesity medicine, and the adolescent, pediatric and adolescent gynecology. So I just want to do it all. I want to take care of all women out there.
So this woman knows what she's talking about, y'all. Everybody pay attention. She's
Well,
got
I
the
know a little
credentials.
bit, not too much, but a little bit.
So I want to jump right into the hot button topic that this is why I invited you in the podcast. I feel like so often the women on my couch are struggling with what they think is depression or anxiety, but I can see it's something hormonal. And not because of my training, I am a health psychologist, so I do look at the whole person, but I point out patterns. And the pattern for these women is so often when they start describing a cycle, I'm like, listen, mama, when we say a cycle, like you should be thinking about your menstrual cycle. You should be thinking about your hormones. So I guess I want you to explain to listeners out there, how do we distinguish? Is it something going on with my hormones, whether it's PMDD or perimenopause, or am I depressed or am I anxious? Like, I see that they should be talking to you, but then what would you be telling a woman, and how do you help them understand, like, what's the path forward there?
That's a loaded question.
I know.
But it's so interesting to first recognize that it's a combination, I think, of everything.
Yeah.
Yeah, it's great that you have that mentality to think outside the box and not just think as a psychologist, psychiatrist in your own specialty, because we tend to just be biased as to if they're coming to see me is because they have a pre-existing psychiatric condition, or because they are predisposed, or because their family history shows that they've suffered from this. So because I had that, you may have that. So by default, they go to you.
Right.
So thank you for having that big picture, because you're right. There is a hormonal component that I think influences it all, right?
Yeah.
We all women have our cycle, right?
Yeah.
We have our periods. Some women have regular periods where they have it every month, and they have no sort of PMS, PMDD. And when we talk about that, PMS is premenstrual syndrome. So it's a milder form where you have all these symptoms where you feel bloated, your mood changes, the patients recognize it themselves. And to this day, with all the knowledge out there, they're basically diagnosing themselves because they recognize that this is a pattern.
Yeah.
So before they come to you, they already think, there's a pattern. But when you recognize it, how do you know? Well, you need to see a gynecologist, or I should stay here, or I should stay. So in general, how I approach it, in my point of view as a gynecologist, I always get that menstrual history.
Okay.
And I do ask them, what are your symptoms around your period?
Yeah.
How are your periods and what are the symptoms? Usually the symptoms are supposed to be there, right? So when is it a problem?
Right.
And I always say if it affects your quality of life. Because just like the period is painful because it is an inflammatory process that happens when you release an egg. It's very pro-inflammatory. So the management doesn't always have to do birth control pill, but you can just take ibuprofen, Tylenol, any anti-inflammatory. Same thing with the mood. You may just the fact that you're bleeding for 7 days, that's annoying.
Yeah.
And if you
No,
guys
right.
then would have that period, I wonder how you would respond. Nothing personal, but
Hashtag
right.
grateful. Yes.
So you may feel like annoyed, just annoyed
Right.
at the fact. But when is it a problem? Well, when it's disrupting your quality of life, when the people around you are noticing that you're not the same. And at that point, when they come to me, I don't think of sending them to you
Mhm.
as a psychologist to be like, okay, well, she needs
Right.
medications. When I always tell them there's always psychotherapy and non-medical management
Sure.
to manage the symptoms, even without my hormonal management.
Yeah.
That's my default. Recognizing, I think, is the first step, right? Like being on denial, not knowing affects. Once you're aware, you may be able to control it. So I always advise on that. And I do offer the birth control pills.
Okay.
It depends on the patient because some of them are already looking for contraception. So it's very convenient. And I present it like that. The birth control pills can help you for the contraception and also to stabilize this mood. But then you get the patient that say, but I thought the birth control pills can also make you crazy.
Right.
And that's very
Yes.
common.
Yes.
And let me tell you, I'm sorry I don't have the answer because unfortunately I have the same pill given to different patients and they all respond
Yeah.
different.
Yeah.
Okay. There is some evidence that the progesterone only
Yeah.
birth control pills are the ones more associated with the mood when compared to estrogen and progesterone, because whenever they say the pill, they don't necessarily know
Different
what
types of
even
pills.
there's different type of pills
Right.
and there's different amount of each of the hormones, not
Right.
only estrogen and progesterone, but different type of estrogen. Usually it's the same type of estrogen or this we have a new one now, and essentially different type of progesterone and the dose.
Okay.
That's what makes so many birth control options. There's a lot of them. But specifically, there's ones that are only progesterone for patients that have migraine with aura, hypertension disorders, predisposition to breast cancer, but they want to stay away from the estrogen. We tend to do those progesterone only pills.
Okay.
So, yes, my go-to is birth control pills. However, when they have any pre-existing conditions, psychiatric in the sense of yeah, I did suffer from anxiety, or I was evaluated already by a psychologist, psychiatrist, and I was placed on these medications. I don't stop them and I put them on birth control pill. I usually say you want to make sure that you get that underlying condition evaluated.
Yeah.
Because sure, you can have both the PMS, PMDD, and also have anxiety, depression,
Yes.
right? So
Which is
I
made
think
worse
it's a challenge.
Yeah.
And I agree. I think that when you have a predisposition, it can be worsened by the hormonal changes. That's the way I see it. Because the actual hormonal changes are going to give you
Every woman's going to feel a little bit off. Yeah, something.
Right.
Yeah.
But to the point that it affects your quality of life, to the point that you seek out help that you're not functioning, there's where I think we definitely need this collaboration for both of us.
Yeah, and that's what, as a psychologist, when I'm seeing that, like, I know what a baseline feelings around PMS or your period should look like, and now this is bigger, this is more, and so now we need some kind of intervention. And and that intervention, what you're saying is basically it's complex, right? It could be that we start the patient on Lexapro, it could be that we start them on low-estrogen, or it might be that we start them on HRT, right? Like there's different pathways that tailor to the patient.
That's a good point. Let's distinguish those two a little bit, because when will you do birth control pills and when will you do HRT?
Yeah.
You mentioned HRT. HRT is hormone replacement therapy, and I leave that one more for my perimenopausal, menopausal patients, and the birth control pills more for my young patients in the reproductive period. So there is a gray zone in that perimenopausal, and just for definition purposes, menopause is when you have a whole year without a period. Perimenopause is thought to be 10 years before that last menstrual period.
I realized it was that far advanced. Okay.
It is. So it is. That's what we tend to say. It's a big range, but it's good to define it, because when patients experience those perimenopausal symptoms, name it hot flashes, mood changes, mental fog, vaginal dryness, lack of sex drive, and the list goes on. They don't have them all at once, but they may have subtle changes. They may start as early as 40 years old, or even in the later 30s. Because if your last menstrual period is at the age of 49, for example, 10 years before it's 39.
Yeah.
So it's recognizing that those symptoms can happen in an earlier age than what people tend to think. Menopause is something for old people, but what is old? What's the number? So in that gray zone of 40 to 50, you're still in your reproductive years, especially now that we see so many women doing their
Right.
careers and they're delaying a little bit their fertility and they kind of forget about their biological clock, which I always encourage, and I'm glad we're having this conversation, and I know we may touch base on the fertility
Yeah, we're
concept.
gonna get to that.
It is very common that I see a lot of patients with infertility. This period of 40 to 50, they're still in the reproductive years, so many of them are already on birth control pills. However, 47, 48 years old, you're closer to the menopause range, and it is thought that the amount of hormones, or it is a fact that the amount of hormones in a birth control pills is significantly higher, 10 times higher what is in a HRT or hormone replacement therapy.
Okay.
And that's why I
kinda
wanted
had it
to
reversed.
I know.
Yeah.
So I'm glad that we're talking about it, because these are the little things that matter so much, because once they understand, they're more likely to then demystify or lose the fear. It's kind of like, what's the most important thing on a chair? Is it the back? Is it the legs? It's the screws, right? The screws is what's keeping the chair together. You don't have the screws, it's gonna fall apart. So it's those little things that you don't see that's holding you together. So same thing with the hormones and the mood, and it's recognizing those little things that is what matters. HRT is 10 times less what is in a birth control pill. So somebody that is 48 years old is better off to be on HRT than on birth control pills. And I have many patients that say to me, do not dare to take me off the birth control pills. I love how I feel. My friends, their husband got a vasectomy and they are dreading it. So they stop the birth control pills, and then it uncovers these symptoms.
And that's why we're having this conversation, because so often I tell some of my women, depending on what I see, that like I will recommend that they go to you to use birth control as an antidepressant or anti-anxiety, because it's going to even out some of that. But then we're dealing with the underlying issue. We're not putting a Band-Aid on the symptoms of the issue. We're kind of going to the root, which I see as a cyclical thing, right?
And it's hard to recognize. So I appreciate that you're thinking of the big picture to also consider the hormonal interventions in general, either in their fertility years with birth control pills, or even the young patients that just got their periods and it's like.
But now let me ask this, and again, like I speak the health side of things, but I'm not an MD. So I have women who'll come to me and they'll say, but okay, I got my blood work and they said my hormones are fine. Now, my argument to that is, but that's a snapshot. That's your hormones on that day. Where are you at in your cycle? What if we checked your hormones on a different day? Like, so what is your feeling around that? How do is that accurate? If a woman goes for one-time blood work, can she say her hormones are okay? Or do you need a different way to like kind of examine or get the right picture of that?
I love that point, because I feel like I'm talking about it all the time. And I think that's the biggest problem of why so many women have been dismissed of their symptoms, because unfortunately their providers go based on numbers and not on clinical symptoms. I'm a little bit on the opposite spectrum, and I say, forget the labs, I don't care the labs, I go clinical.
How do you feel?
And they're like, what do you mean? You're not going to check my hormones? What if I have an imbalance? And there's no such thing, let me tell you, because how are you going to tell balance versus no balance? And we don't base our management based on the labs, at least I don't, because unfortunately that's what has happened. The labs are normal. And here's why. Yes, that's a good way to put it, like a snapshot, because during the month, our hormones change. You get that LH surge that is supposed to trigger ovulation, and then the spike in the progesterone, estrogen, and all those changes, beautiful dynamic that happens that then causes the period and the symptoms, but that depends on where you are in the month. So I personally, well, depending on where we're talking of a young patient that
Mhm.
thinks she has PCOS.
Mm-hmm.
I do look at some of the values because
Mhm.
DLH is supposed to be double the FSH, etc. But in that perimenopause, menopause, which is the one time that the patients come and they're like, I need to check my hormones, something is wrong. And we check them, and because they still have a period, the FSH and estrogen are those hormones that tend to, when you look at the lab values and the reference, there is a postmenopausal range.
Mm-hmm.
But you know what it is? For postmenopausal, the FSH is more than 23, and for estrogen, less than 15. Now, you'll be surprised how many times during the month those numbers fluctuate, especially if you still have a period,
Yes.
they're going to fluctuate.
Yes.
But that doesn't mean you're not having the symptoms, and it doesn't mean you don't need hormones. I can tell you, there's so many patients that tell me, Doctora, I've been told that my numbers are normal. I'm not crazy. And that's when you get your patients, because the gynecologist does the blood work. They're normal. They fluctuating. They shouldn't be used to determine your status. And then they send them to you. And then I'm sorry, you're stuck with this patient that truly will benefit from hormone therapy. And
that's why I believe it's about you keeping a record, a journal, like your own, like you should be your own historian.
Yes.
And I was just speaking to a woman just the other day, and it's just as basic as tracking your cycle and seeing, like, are you regular? If you're 20 days and then 33 days and then 12 days, like, okay, already that's just numbers. But then what are you feeling?
Yes.
And what do you feel? What are the symptoms? And that's when we can start to, and in medicine, you can do tests. There are labs and levels, but in my world,
I know. What do you do?
It's just clusters of symptoms.
Yeah.
And some of it is
documentation, history, seeing a pattern.
Yeah, and so we do a lot of differential diagnosis, trying to guess. But I like to step out of just the mental and look at, okay, well, is this PMDD? Is this PCOS? Is this are you? Is it something environmental? Is it like, what are we looking at?
And or medications.
And so, but what we need to hear is that the patient's saying something's wrong.
Yes,
and we don't know what the hell it is, but you're not feeling good.
But you see, that's the key. I think recognition is very important. Like with any psychological, psychiatric condition, it's how many times the denial isn't that the first step when you don't recognize that something is wrong. Once you recognize something is wrong, just move on and look for opinions, look for second opinions. If you don't feel right, look for something. And especially when you know yourself, you know your history, that you haven't been like this all your life. The tricky part is when you have all your life been like that, you've been untreated, then it gets worse, and then what is it? So yeah, challenging topic.
And just for listeners out there, PCOS, can you define that or explain what?
Yes, so we know PCOS is polycystic ovarian syndrome, which is typically characterized by abnormal bleeding pattern during the month. They tend to have a hyperandrogenic state, meaning like hirsutism, hair in the unwanted areas of the face, acne, acanthosis nigricans. In ultrasounds, they may or may not have those cysts in the periphery of the ovaries. And then in the blood work, we tend to see an increased level of LH and testosterone. Okay.
And PCOS is a hot button because now we're going to talk about fertility and infertility. And so often women, that's one of the questions that sits on my couch. I think I have PCOS. Does that mean that I'm not going to be able to get pregnant? And so we need to get into this. Where does Dr. Paredes sit with, if a woman comes to you and says, I'm having trouble getting pregnant the quote unquote natural way, right? Like, no, then what is your first line? Like, are we looking at PCOS or endometriosis? Are we checking his levels, or which is the one that I think always gets missed? Are you jumping right to IVF?
I love this topic. I love it because it's so common in terms of actually happening with infertility. It's so common into what they come and ask.
Yeah.
So the first time that I see a patient, ideally it should be for well women, meaning I'm not looking at you have a problem or they come already with a diagnosis. I like to do their screening.
We want to get a baseline.
Baseline of like pap smears, blood work, the thyroid. Thyroid is a big factor into hormones and how they manifest. Could actually get tricky with the perimenopause. And I always say, you want to make sure that you rule out the medical component and the medical aspect, because I could give you all the HRT, but if that thyroid is not controlled, You're still going to have your symptoms.
Called you yesterday. I had a woman on my couch, and we were debating: do we go see the gynecologist or the endocrinologist?
Yes, and obviously the endocrinologist is a very comprehensive specialist that I tend to refer as well, even though I am a gynecologist and there's a lot of endocrine in my world, right? And then I deal all the time with PCOS. So when I look at a patient and they come in already with that worry or that diagnosis given by another provider, because they also come like that, do I really have it? Like, do I believe that I have it? I was given this when I was little. Is it still there? Is it something that you get rid of? So there's a lot of like really interesting questions that the patients bring up. And I honestly approach it the same. I do the blood work, I do the history. It's a criteria. And again, it's a syndrome.
Yeah.
You know what happens with syndrome. It's not black and white. You have more than 140/90 blood pressure, you're hypertensive.
Right.
In a syndrome, it's kind of like a diagnosis of exclusion. You have excluded other conditions, and then if you fulfill this, then it's that.
It must be this.
So it makes it challenging. Now, infertility, it's actually one of the features that is associated with PCOS. Like when you read about PCOS, it does say infertility. But here's what I tell my patients, because I have many PCOS patients very pregnant and not desire because they were told that you can't get pregnant because of PCOS. So very important. PCOS, or let's think back that the patient does have it. We have done the blood work, the history, everything confirmed. The ultrasound shows this cyst in the periphery of the ovaries. What I think happens, the physiologic explanation that I give it, is that in the ovary, for you to get pregnant, you need to have a mature follicle that releases the egg, that likely, hopefully meets with the sperm, and then it implants in the uterus. There's a lot of things that can happen to prohibit that, and hence infertility. But in the case of PCOS, it is thought that you can have anovulatory cycles. So even if you have regular periods, it doesn't necessarily mean you're releasing that egg or you're ovulating. And what I think happens is that there's so many eggs. So in my mind, what I think of PCOS, you have too much potential to get pregnant. It's just that all the eggs are competing with each other and it doesn't let one mature. But when we actually help you, because there's ways to help, like letrozole, for example, I give to my patients with PCOS. It's a medication that induces ovulation. Guess what? I have to warn them. You're at increased risk of twins. And they're like, oh, I don't care at this point. They're being so, desire to have a baby that they don't mind, but that's why. Because I'm inducing one of those eggs to mature, but then you're inducing, and because you have so many, then maybe two go out, right? And that's the problem with PCOS. It's not that you're infertile, that you cannot get pregnant. Well, it's that they're competing with each other and you may need that help with an ovulation induction agent that allows that maturation process and that release of the egg. That's what I tell them, because I don't want any more patients coming to me on unwanted pregnancy because their provider told them that they're infertile because they have PCOS. Because it's not that it's not true, but it's because the competition.
Well, and maybe infertile is too black and white a term.
I know.
So then let's get into another controversial one that I deal with. My provider told me that I need to lose weight, and that's why I'm not getting pregnant.
That's a very good point.
So where do we stand on that? I feel like that's tough because we want to have body positivity, but we also want to help women get pregnant if they want to. So then is there some truth to that?
Yes. So the short answer is yes, because what happens in the fat cells, there is an enzyme called aromatase, which increases the amount of estrogen, hence why obesity is associated with endometrial hyperplasia, because you have this increase in estrogen that then makes the lining of your uterus thick, and that's what can prone you to have cancer. But again, you have this extra amount of hormones that is not letting you have this nice balance of up and down in the hormones, and you have too much of one or too much of the other, so you don't have that balance. Therefore, you don't ovulate because you don't have the balance. So that's when actually weight loss is the first line treatment of PCOS. It's easier said than done. I know. But the good thing, in 2025, we have those GLP-1s, which is why I went on and did my obesity medicine training, because it's intercalated in everything. I'm sure you see it at your own level with body dysmorphic disorder, obesity and depression. Like, Let's be real.
Well,
This is it.
and I believe movement is the first line of mental health medicine. So not about weight loss, but just moving your body. And what you eat is going to affect your mood. So I look less at even the like body fat percentage and more like what's led to that, or what can we, like. But the reason I bring this up around fertility is because I think women have felt, is it bias? Is it shame? Is it because I saw a male OB-GYN and he just doesn't like women of a certain size? So there is
That's
some
a good
truth
point.
to this.
There
This
is truth.
Yeah,
Absolutely. We are what we eat, and there is, I think, factors in the diet that we have that we don't even know what we're putting in our bodies, right? So then I also go towards everybody should have a nutritionist, a coach in the gym, a psychologist, and a gynecologist. I think those four will be, you will be very successful, because a lot of the problems health-wise can stem from lack of any of those that lead to obesity.
Well, and the one that I wonder where our worlds overlap is there's so many anecdotal stories. I don't know if there's good research that's been done because we can't manipulate that, but if you're anxious about getting pregnant, then it's going to be harder to get pregnant. And when you finally just let go and say, oh, whatever, that's when suddenly you get pregnant.
Yes.
And I do think that because anxiety is affecting body chemistry, brain chemistry, hormones, like I do think there's a component to that.
100%.
And
I prescribe a vacation.
I encourage my women to track your cycle. So that's not anxiety. You should know when you're ovulating. That's going to help you get pregnant. But if you're trying too hard, or if you're thinking too much, or if that's all you're like, and I think there's I don't know, but I don't know if it's an old wives' tale, or like, do you see that too?
No, yes, absolutely. Okay. I can agree to that. And the explanation I give it is when you're anxious, you're stressed, your cortisol level goes up, and then there is a physiologic explanation that you can get to the bottom of and realize that that could be why. Cortisol, stress, not allowing to make you ovulate and have your normal cycle can influence. I don't think necessarily just because you're always thinking about it, because that's why you haven't been pregnant. It's not the reason, but
it's a reason, maybe.
What's the pharmacology or what's the physiology that is happening inside of you by you manifesting that behavior of anxiety? So yeah, I tell them, go on a vacation.
Yeah, and so many pregnancies on vacation, hot tub pregnancies, like that's where it happens.
Yes.
Now, a woman gets pregnant, and now the fear becomes, especially if they're already talking to me, I'm afraid of postpartum depression. I've already been seeing a psychologist, so am I predisposed?
Yes.
My take on that is, yes, you might be predisposed because if you had a previous depressive episode, but now you're working towards coping skills, or you're on an antidepressant. And to clarify for listeners, you can be on an antidepressant while you're pregnant.
Yes, they're safe.
It's specific ones, but right?
Correct.
Okay.
Yes, I will be more afraid of the untreated psychological condition than the medication itself.
Yeah.
You will be placed in a high risk consultation. I see patients that are low risk and high risk with the collaboration of high risk doctors who are OBGYNs like me, but they don't deliver. All they do is educate the patient and counsel them on the significance of X and Y medication in pregnancy. They know the evidence and what has been out there, and they can tell you to the bottom of the percentage and the likelihood and all that to reassure the patient that it's okay to give this medication. Again, we can only say so much. Look, we've been saying that Tylenol, it's okay in pregnancy, and now we have a statement where now all of a sudden the patients are not going to want to take the Tylenol. But that's a problem, because guess what? If you have a high fever and you don't treat it with Tylenol, it's going to be worse than the Tylenol itself. So please take the Tylenol.
And that's what it is. Like a lot of medicine, whether it's your branch or mine, is we're reducing risk. We're doing the less bad thing. I always tell my patients, do the less bad thing.
Yes.
I bite my fingernails, and you're not going to be able to see it on camera, and you can't see it on the podcast, but I started biting my fingernails to stop biting my lip.
Yes.
So this is better. This is still bad, but it's less bad. So we want to do the less bad thing.
Yes.
So a woman who is worried about postpartum, or who has a predisposition, or who does have a difficult pregnancy, can be on an antidepressant. Yes. But then now if we're worried about the postpartum, what does Dr. Paredes say about that? Like, what is your take on postpartum? I have my own opinion, and I'm going to offer it, but I want to hear yours first.
Yes, thank you. I'm curious to hear yours. I mean, I send you my patients so you can take care of it. And I do take care of my own as well with medications, because, so this is what I would say. The first thing is recognition.
Yeah. that
we
this
have
is
to
more than.
recognize it.
Mm-hmm.
We have to diagnose it.
Mm-hmm.
Because I think there is a lot of undiagnosed postpartum depression for whatever reason.
Well, because
Either
it's
fear
supposed
of
to
the
be.
stigma,
Yeah.
fear of child services and whatever consequence it
Yeah.
might have,
Yeah.
a sign of weakness that they don't want to put out there, or instead of a sign of strength that I'm recognizing that something is wrong.
Well, but with that, I think the sign of weakness, it can depend on your culture, meaning like big C
Yes.
culture or small c. So, if you're Hispanic versus Caucasian, but also like, what is my family dynamic, right?
Yes.
And if my mom said, well, I did it, then I guess mom did it. So it's not even culture, it's just my world.
I agree.
I just went to see a comedy concert recently, Marcelo Hernandez, and he was talking about growing up Hispanic in Miami, growing up Cuban, and he said, I thought I had ADD, and I wanted to get ADD, but my mom said, you don't have ADD, so you know what? I don't have ADD. I tried to get it, but she said you can't have it. So that's and I think sometimes that can be the case, that a person feels like, I know this feels wrong, but then if my family is telling me, or my culture is telling me, yeah, but this is just how it is, or it's tough being a new mom, and you go, oh, okay, I guess that's all it is.
Which is why I think that you should be involved with all my patients, just to have that touch base and have somebody to talk to, and have somebody unbiased out of the family that can really tell you, well, that's not the case.
This is too much.
In the rest of the world, you know only what you're exposed to. So yes, going back to that recognition. Once it's recognized that there is something going on, and how will you know? Well, we have questionnaires that we give the patients. We do it at the beginning of the pregnancy. It's a postpartum depression questionnaire, even though it says postpartum depression questionnaire. We do it at the beginning of the pregnancy because it asks questions like that will be able to detect anything, an underlying likelihood at the beginning. Then we do it towards the end of the pregnancy. And then definitely, if you have a pre-existing before the pregnancy, you're automatically, in our minds, or at least that's how I practice, as a risk factor for postpartum depression. And basically, how do we diagnose postpartum depression? It's with this questionnaire, depending on the score, and the talking. And of course, the big questions: have you thought of killing yourself? Have you thought of killing your baby? Or homicide, suicide ideations? But sometimes it may be as subtle as just anxiety.
Yeah.
And that's so tricky, because is it postpartum depression, or is it an anxiety so bad that may get you depressed because you're not able to function, you're not able to enjoy your baby because you're constantly making sure the baby's awake, or you're thinking and you have these thoughts that something is gonna be wrong.
God. Have you seen, now they sell, my kid was too old so I didn't deal with this, but now they have a special baby monitor that is an ankle bracelet. Oh my God. And the baby kicks it off, and then you think your baby's heart stopped. And I don't like this thing.
I don't like it either, because, I never had it with my kids. So, but I understand if somebody lost a baby.
Yes. Okay. Yeah. Circumstances matter, but I think it mostly elevates anxiety because
I think so.
So my 2 cents is that I think there's like 10 to 15% of women postpartum who, due to hormones and body changes in the 4th trimester, that there's like a chemically induced depression.
Yes.
But I think like 80-85%, it's a combination of sleep deprivation, not getting the support from family, or like letting the baby be held by others, and pressure around breastfeeding. If when I get a woman to wean off the breastfeeding and let the baby take a bottle, or go sleep at your friend's house and let mom or hubby take care of the baby, suddenly they feel so much better.
I agree.
And that's how that's a differential diagnosis for me to see, like, well, if it went away once you got a good night's sleep, if it went away once you started bottle feeding, well then it was those circumstances, right?
Yes.
We didn't need to change brain chemistry.
Yes, but there's certainly a brain chemistry there. And I think, we've talked about it before. There is this medication now, Zurzuvae, which is a medication that works at the, receptors in the brain that have to do with GABA and all this, neurotransmitter balance, that somehow the hormones and the, other stressors affect it. And yes, there is a medication, because if you're not able, despite the sleep, despite the support, despite all that, you're still not good. What are we going to do? I don't want you to feel hopeless. There are things, there are antidepressants, and there's this now new medication for postpartum depression that is just 2 weeks, because the problem with the antidepressants is that they take time to work.
Yeah.
It takes at least 6 weeks is what I
Yeah,
normally
4 to 6
quote,
weeks until
right?
something happens.
Until
Yeah.
you can see
And you
an
want something
improvement.
right now when you're finally asking.
Absolutely. And we're talking about a baby, we're talking about a mom, and we're talking somebody who's sleep deprived, who's through hormonal change. And you don't know what it is, but you want to help them. So definitely psychotherapy, definitely all those what you just mentioned, the medication. But the most important thing is to not feel alone. And I think that's the biggest problem when they isolate themselves and they think that they have to meet these expectations, and because nobody went through it and they're going through it, they're wrong or they're weak or they're bad. Get out of that. And that's what I would hope that the listeners.
Well, and my 2 cents there is that I see a trend of women waiting later to get married or to get pregnant because more women are pursuing education and career, which I love. But then I think then women who took that approach to getting straight A's in college or doing great in medical school, whatever, now you're taking that same approach to being a mom. And being a mom is not the same type of thing. You can't like study harder or go to the gym twice as hard or whatever you were pursuing in other aspects of life. You can't kind of approach it the same, but a lot of these women was like very
that's what you're used
driven.
To. Yeah, you don't know anything else.
I'm gonna mom the hell out of this thing. I'm gonna be the bestest mom. I'm gonna do the most reading.
Such a good point. I feel like I'm getting a therapy with you here because that's how I feel.
Yes.
As a doctor and now mom of 3, I could tell you I probably went through something undiagnosed because I was telling myself, diagnosing myself and managing myself. So I couldn't agree more. It's
comparing
hard.
notes with other moms, getting support. Yeah, not doing this alone. Yeah.
Yes, I think that's the key. And then having support like you. And I thank you so much for being there because sometimes women just want to talk.
That's it.
And you like to listen to women?
Yeah. Because I explain to everybody, like, it's not, I'm in a unique position that I can listen unbiased. If you were my wife, I might listen differently because I'm thinking, when you're telling me this, what does this mean for me? Or is there going to be ramifications? Or how is it? So I'm wanting it to go a certain way because but if I'm an unbiased, I'm not your husband. I'm not your dad. I'm not your brother. So you can just say it freely. And I'm not thinking, and it's not even judgment. It's like self-preservation, self-concern. Like, like if I say, yeah, you should change careers. Well, if I'm your husband, I'm like, oh, but baby, we got this mortgage, and I don't know. So I'm thinking about how this is going to affect me.
Correct.
But we can just focus on you in that moment, and then from there, then we make a plan, right? Like it's not just listening, but it's a lot of activity, behavior change. Like I tell all my patients, you talk to me for an hour, you're going to feel nice, but that didn't do anything. Like the real magic happens when you go out there and you do the homework. Like so you have to do something different, but I'm going to give you
resources and tools.
You don't need to come up with it on your own.
That's all we need. Kind of like when you go see a nutritionist. Well,
yes.
You don't want to eat the fat food, but what do I eat?
Right.
Give me the alternative so that when I feel that craving to eat something, it's not necessarily I eat too much, it's what do you eat?
And something realistic. Because I think the problem with whether you're listening to TikTok for mental health or fertility advice, or whether you're you read a book, like I think sometimes it's not tailored to you. Like, what's your lifestyle? Talking about the nutritionist idea, like, okay, if you don't have access to a Whole Foods, well, I'm not going to tell you to eat some random organic thing. Like, we need to work within your world.
Correct.
And so a lot of times with the patients that we share, I'm looking at, okay, well, are you doing this alone? Where's the father of the child? Do you have family support near? Like, what does your maternity leave look like? Like, all these things matter.
I know.
I have a patient who works at Google or Apple or one of these tech companies, and she's got like 13 months maternity leave. That's very different. My mother, there's a Freudian slip. My wife took the exact 3 months and that was it. And it was like right back to it. And it's, so all these things matter about you.
Absolutely.
Oh, we should tell the listeners out there, Dr. Paredes has an involvement with Zurzuvae. What is your affiliation, or are you just a spokesperson?
I just speak for the company.
I need to put a disclaimer.
Yes, absolutely.
We're not promoting any one drug. It is the only drug that does this, though.
Correct, and that's why I'm so passionate to educate people about it, because I want providers to have options for our patients.
And that's what we're really talking about today, whether you're listening on the podcast or whether you're watching on social media, that we're doing kind of two sides of the same coin. We're looking at women's well-being and how you're coping and how you're functioning, and you're coming from your angle and I'm coming from mine, and we have different ways to provide, but like I want women to know, well, it might be this or it might be that. Like, let's explore all options.
And
let's have conversations.
It's not black and white. That's what I usually tell my patients. you just try the birth control for 3 months, see how you do.
Exactly. If you feel amazing, then you're going to regret you didn't do it sooner. If you feel horrible and you spin out, we stop.
That's the
okay.
one thing that I've noticed, that I went into medicine thinking it was black and white, and it's different grades of gray. There's different shades of gray. It's not black and white. You know, when they come to me, okay, what are the side effects of birth control pills? Sure, I can tell you what it says in the insert.
Right.
What are you going to experience? I don't know.
Right. And that's what, it's just a conversation.
Yes.
Thank you for having this conversation with me, Dr. Paredes. I appreciate you. I appreciate how you take care of my patients.
And you of mine. I want to keep talking.
You've got to go do surgery, girl. This is Dr. Jardina with Therapy Without the Couch at Coral Gables Counseling Center. I'm here with Dr. Ingrid Paredes at FemCare OB-GYN. Thank you for listening, and we hope to see you soon.
Yes.